eyes on you.
No pressure.
Okay.
Alrighty, so antidepressants, objectives for the lecture is just to define depression, describe medication option treatments for depression and side effect profile, summarize the benefits of somatic therapies. Depression is defined by depressed mood and loss of pleasure or interest in nearly all or all of one's usual activities and pastimes for most of every day for 2 weeks. It can be characterized by insomnia or lack of sleep, lack of appetite or weight gain, mental slowness or loss of concentration, feelings of guilt, worthlessness, suicidal thoughts and behavior. It's important to differentiate between normal grief and sadness and depression. So normal grief and sadness is something that you'd have happen after like the loss of a loved one or loss of a job. You know, you feel it for a few weeks and you get through it. It goes away. Whereas depression can last up to 6 months or longer. It may not always have a trigger. It may not always have a reason why it's occurring. Those are the two main differences. The pathway behind it is not completely understood. It's believed to be a lack of serotonin and, monoamine neurotransmitters, which are serotonin, norepinephrine, and you'll see that a lot of the medications that we're going to talk about are aimed at increasing both of those or at increasing the monoamine neurotransmitters. Treatment is often combination treatment, so your patient will be on meds. There's also depression-specific psychotherapy, which could just be like cognitive behavioral therapy or group therapy, talking to a therapist. And then you also have your somatic therapies, electroconvulsive therapy, and transcranial magnetic stimulation, which we'll talk about more in depth at the end of this lecture. So drug selection. All of the medications, when you're initially starting off, you're going to be on them for 4 to 8 weeks at least to assess efficacy. It takes a few weeks for them to build up in your system. So for that reason, these meds are never used PRN. They're always going to be like once daily or twice daily meds. And we start them low and gradually increase them. If therapy were to not be effective after the 8 weeks, the 4 to 8 weeks, you could increase the dosage. You could switch to a drug within the same class. You could switch to a drug in a different class, or you could also add on a second drug. You'll see in a lot of the lectures that people may be on more than one drug. And you also, it's like a very important education piece for your patient. You want to encourage them to continue taking the medication, you know, past that 4 to 8 weeks so that we can make sure that the med is working. They may feel discouraged if they're not feeling better right away, but we just got to educate them on how the meds work. Also want to teach your patient that after that 4 to 8 weeks, when they do start feeling better, some patients believe like they're cured and the illness is gone and they can just stop the med, but really it's just the medication working. So we want to make sure that we continue to keep taking the med. And because of a lot of the antidepressants that we're going to be talking about have nearly the same efficacy, selection among them is based largely upon like tolerability of the patient, the side effects, the patient and the doctor preference, or costs. It's also beneficial to, in some cases, we'll try to match the medication we prescribe the patient with the side effect they're having. So if they're having depression that comes with insomnia, we'll give them a medication that will help them sleep at night. Or if they're having depression that like presents with CNS like stimulation, then we can give them medication that has like sedative side effects. Next, so suicide risks with antidepressants. All antidepressants run the risk of suicide. It's generally higher when you're first starting treatment, but it's always there, the risk of it. It's higher among children, adolescents, and young adults. There are black box warnings on all antidepressants. And you want to make sure you're observing your patient closely for suicidal ideations or changes in their behavior, worsening moods, things like that. So when a patient comes into clinic or the doctor's office and you're assessing them, you're not only asking them these questions, but you're also physically observing them Are they more disheveled? Are they more withdrawn? And it can be difficult, especially starting out as a new nurse, to ask somebody like flat out if they're suicidal. But in the hospital, like when we do admission questions, that's really what they want you to do. Like every day when I admit somebody, I have to ask them, "Are you having any suicidal thoughts?" And then when they say no, you have to like look at them and use eye contact and say, "Do you want to die?" Like you have to physically ask them that, which it is uncomfortable when you first do it, but it can help save a lot of lives, and it's important to do. When these medications are first prescribed, the doctor will see the patient every week for 4 weeks, biweekly for 4 weeks, monthly for 1 month, and then periodically. And to decrease the risk of a patient committing suicide, we're going to prescribe the smallest number of doses as possible. And then for inpatient, you always want to make sure that your patient swallows the med and isn't like cheeking it. And what do we do if they are seeming like they're more suicidal or more withdrawn and agitated? We could switch to another antidepressants, but like I said, they all carry the same risk. Yours is doing it too. It's like fast forwarding me. It's okay. I think I paused it. Sorry, I lost my train of thought. Yeah, so we could switch to another antidepressant, but like I said, they all carry the risk of suicide. But from research, the risk of a patient untreated, depressed patient untreated, has a higher risk than a patient who is treated to commit suicide. So there's still the risk, but it's higher for a patient being untreated. And then of course there's always temporary hospitalization if you think a patient is very unstable. So first med that we're going to talk about is SSRIs. These are the number one first-line treatment for antidepressants. The prototype drug we're going to talk about is Prozac. So how serotonin reuptake inhibitors work. So basically, serotonin is a monoamine neurotransmitter. You guys have probably heard that before. We want to allow for the monoamine neurotransmitter, the serotonin, to remain in the synapse and to accumulate there. So we're basically inhibiting and blocking the reuptake of the serotonin, which means it will remain in the synapse and accumulate for the patient. The therapeutic uses of SSRIs are listed here. We're talking about depression, but it's also used for many other different disorders. I'm sure most of you have heard about it. We're going to talk about a few of them today and on Thursday. PMDD, you may not have heard of. That's just premenstrual dysphoric disorder, and that's just heightened menstrual symptoms. So increased irritability, anxiety, depression 1 or 2 weeks before your period. The pharmacology, so it's well absorbed or orally, even with food. It has a prolonged half-life, 4 weeks to produce steady state effects. That's why it takes a little bit to build up in the system and to start working. Its most common adverse effects, sexual dysfunction. The mechanism is unknown, but it does occur in 70% of men and women. So that's definitely a big teaching point that you would want to talk to your patient about, because that can be very life-altering for a lot of patients and concerning for a lot of patients. Also nausea, headache, CNS stimulation, and weight gain. You're also at an increased bleeding risk. It can increase the risk of bleeding in the GI tract and other sites by impeding platelet aggregation. So you want to use caution in patients with previous GI bleeds, ulcers, or someone who takes a lot of NSAIDs, because we know that also affects your platelets. And serotonin syndrome, that's something that you'll probably hear a few times over the next couple of lectures. It's something that can occur in anyone who's taking a med that builds up serotonin. It's a buildup of serotonin in your brain and spinal cord, and this can begin 2 to 72 hours after starting treatment. It's really unknown why it happens. It's not that the patient took too much of the med or overdosed, it's just some patients experience it. And that presents as a mental status change, agitation, confusion, incoordination, quick involuntary muscle jerks, excessive sweating, and tremors. Deaths have occurred from it, but it does resolve spontaneously after stopping the med. So the patient would still need to be coming into the hospital or the doctor's office, but you can like teach them that if those symptoms do occur, to just not take any more doses before they come in. And then you can have withdrawal symptoms. So just like you taper a patient up, when you're taking the patient off of it, you're tapering it down to prevent withdrawal symptoms. That can be dizziness, headache, nausea, sensory disturbances, tremor, anxiety, and dysphoria. So always taper those slowly. It's not teratogenic, so patients do take it while pregnant, but you want to teach your expecting moms or pregnant moms that they are at risk for neonatal abstinence syndrome, which is basically the baby going through withdrawal of the med once it's born. That can just be like irritability, abnormal crying, tremors, respiratory distress, and that's just supportive care. The treatment is supportive care and resolves in a few days. So drug interactions with Prozac. So MAOIs, we haven't talked about that yet, but we will. It's used for depression. It works in an entirely different way, but it also could contribute to the buildup of serotonin. So having the patient on both of those at the same time just increases their risk of serotonin syndrome. Tricyclic antidepressants. Prozac can increase serum levels of TCAs and lithium, so if your patient were on both of them, then you're at an increased risk of toxicity. Also, antiplatelets and anticoagulants, because we already know that Prozac decreases platelet function, so if you're putting your patient on another medication that can also decrease platelet function, then you're just worsening the risk of them having a bleeding issue. Other SSRIs are listed here. You'll see these a lot. You've probably already given a few of them. And at the bottom, we have serotonin norepinephrine reuptake inhibitors, SNRIs. This is another class of drug that selectively blocks serotonin, but also norepinephrine. It has, we don't need to get too much into it. It has the same exact side effect profile, indications, medication interactions as SSRIs. It just also blocks norepinephrine. The two most common drugs given for that are listed there, but it's essentially the same med, just also blocks norepinephrine. This is just a question I have on SSRIs for you guys. Which of the following should the nurse include in the discharge instructions when educating the patient on Celexa? Nausea and headache can occur. You can take this medication as needed when you are feeling depressed. If you notice your symptoms worsening, please just continue to take the med. It will start working soon. If you notice any stimulation, nervousness, jitteriness, insomnia, you can take the medication in the morning. It's select all that applies. What do you guys think?
It's not the
A and B. And D.
I and D?
Yeah.
Anyone
And
disagree?
C. And C.
And C.
I don't know.
And D.
Why do you think it might not be C?
Well, because it's taking it from more
Yeah.
Indeed, signs of serotonin syndrome.
I think so.
Yeah, she said it was
But they can't
tremors,
cause
jitters.
bleeding.
Yeah, I think D might be. I think yeah.
Well,
But
so,
they can cause insomnia, and that would just mean take it in the morning so it doesn't affect you to sleep.
yeah. I'll show you guys the answers. So, A is right. That's a normal side effect. B is wrong because remember this is a daily medication. It has to build up in your system. We're not taking it PRN as needed. C is wrong only because, like you had said, it might be like the medication isn't fully working yet. That's true, but if your patient is saying I'm feeling worse, you should definitely pay attention to that. Definitely do like a suicide screening, and just make sure that they're not suicidal or they're not unstable or things like that. They might not be. It might just be waiting for the med to kick in, but it's definitely not something that you want to ignore. And then B, this is just a CNS stimulation that it's getting from the med, which is one of the side effects. The serotonin syndrome was more like a change in mental status and things like that. So this, we're just telling them if you have those feelings, which everyone might not, but if you have those feelings, you can take it in the morning rather than taking it later in the evening and it keeping you up all night.
What was the serotonin syndrome symptoms again?
The serotonin syndrome, it's more like a change in mental status. You have, they're more concerning. So you have change in mental status, agitation, confusion, incoordination. You can have like myoclonus, which is those muscle jerks, involuntary ones. I think you guys talked about that with like schizophrenia and those meds. Excessive sweating and tremors, and you can ultimately have death from that. And these are, I know they didn't put it on your actual PowerPoint, but it is all listed in your guys' book too. So everyone feel okay with those answers?
So basically, the takeaway from C, right, would just be if they are starting on an SSRI, just make sure they're not getting worse. Like worse is like a red flag.
Yeah.
Okay.
If they're telling you like I feel worse, I'm more depressed, blah blah blah, you definitely want to assess them for suicidal thoughts and ideation.
But if it said they weren't feeling anything, yeah, they didn't feel a difference, then you tell them to continue to take
Yeah,
it.
if they're then you would just it was kind of to like trick you guys.
You tricked me.
Yeah, if they were just saying, oh, like I'm not feeling great yet, like what's the problem? Then you'd educate them. It may take a few weeks.
But it would be if it was like, you know, if the symptoms getting worse, contact your physician would be good.
Yeah, exactly. Yep. So next drug are TCH, tricyclic antidepressants. Mechanism of that is just they block the neuronal reuptake of two monoamine neurotransmitters, like we talked about, norepinephrine and serotonin. So kind of like SSRIs, but they also block receptors for histamine and acetylcholine. The therapeutic uses are listed here. Again, they are used for multiple different things. I just wanted to talk about fibromyalgia and neuropathic pain. The last class told me that you guys haven't learned about fibromyalgia yet, right? So I just didn't want to confuse anybody because those are not psych disorders. Fibromyalgia, it's basically just like a chronic pain disorder that patients have that it's like a widespread musculoskeletal pain and there's really no like attribute to it. There's no like changes in like bones, joints, or anything like that that can be found like on testing. So it's believed possibly be an abnormal central processing of pain signals in the brain. So norepinephrine and serotonin are involved in pain perception. So somehow these medications help with that help with those patients feeling those symptoms because like the serotonin and all of that. It's not doesn't matter for your guys' test, but I just thought maybe someone would be curious about that. And then also like insomnia, ADHD, OCD. So tricyclic antidepressants, they have a long half-life, which again is why it takes up to weeks for it to start working, like most of these meds. It's usually just a single daily dose that the patient will get, just once daily, but it is individualized dosing, so you will see a few different doses. And again, a therapeutic trial should not be considered a failure until it's taken for at least 1 month. TCA adverse effects, so sedation, and that just comes from the block of the histamine receptors because we're already having like a little bit of CNS depression. So further depressing it with histamine can cause sedation. Orthostatic hypotension, that's like a big teaching point for your patient. So it blocks alpha-1 and adrenergic receptors on blood vessels, causing a decrease in preload, which can then cause orthostatic hypotension. So you want to teach your patient, make sure when they're moving positions, they're moving slowly and taking their time. Also, if they have persistent dizziness and lightheadedness when walking and doing daily activities, to lay down until it passes. But you also want to teach them, like, if they're consistently doing that and it's happening more than once or twice, to like call the doctor. That's like a pretty big inconvenience, and also they can injure themselves and pass out. So that may be like something that the doctor changes the med or tries a new med. If the patient's in the hospital, you'll definitely be checking orthostatic blood pressures and often holding the dose if the blood pressure is too low. The anticholinergic effects, so you guys have heard about anticholinergic effects probably a ton of times. So you're just blocking the cholinergic receptors, so you're going to get those drying symptoms like dry mouth, blurred vision, photophobia, constipation, urinary hesitancy, and tachycardia. Cardiac toxicity, this is usually only a problem in patients that already have a cardiac history when starting the med. It's not likely to cause issues in patients who don't have any history. They affect the heart by interfering with the heart conduction, so it's putting your patient at risk to experience dysrhythmias. So you'll definitely see these patients getting an EKG prior to starting treatment and then a few times thereafter, just to keep a close eye on them. Also with seizures, it lowers your seizure threshold, so the patient may have to have their meds adjusted when they're getting started on TCA, have their seizure meds adjusted when they're getting started on TCAs. Hypomania, it can cause a mild form of mania. If this develops, the patient should be evaluated to determine if it's from the med that they're developing this, or it could be an underlying bipolar disorder. It could be an underlying bipolar disorder. Oftentimes, you'll hear, like in the next couple of lectures, that patients don't usually have just one disorder. They can suffer from 2 or 3. So if a patient starts a TCI and starts developing mild mania, the doctor would want to assess for maybe an underlying bipolar disorder, or it could just be the med. And then also adverse effects are the risk of suicide. TCA's drug interactions, monoamine oxidase inhibitors. We're going to talk about that next, but that's also med used for depression. And when combining TCAs and monoamine oxidase inhibitors, you're at risk to develop severe hypertension because of the adrenergic stimulation on the heart and blood vessels. Also, indirect and direct acting sympathomimetic drugs. So direct acting, like your epinephrine and dopamine, TCAs can potentiate their response and give you like a stronger response to those meds. Whereas indirect acting, like ephedrine and amphetamines, TCAs decrease their response and you won't really have any effect, or the med won't be effective. Also, CNS depressants, just because you're already having a little bit of CNS depression, so when you're taking CNS depressants like alcohol, opioids, antihistamines, barbiturates, you're just at a further risk for CNS depression. So TCA's overdose is life-threatening, and that's just related to the cholinergic blockade that occurs. You'll see cardiac dysrhythmias, hyperthermia, flushing, dry mouth, confusion, agitation, hallucination, seizures, and even coma. To reduce this risk, the doctors will only supply 1 week of medications at a time for high-risk patients. And so the treatment for that, you'll do a gastric lavage and activated charcoal, and basically both of them just try to get the medication absorbed in the gut and out of the gut before it continues reaching systemic circulation and giving you its full effect. You'll also want to treat dysrhythmia, as the patient will definitely be on like a cardiac monitor, and you'll be monitoring electrolytes and things like that. So for dosages and routes of administration, again, starting low and increasing gradually, and that's just because of the side effect profile. Onset of the therapeutic response is the same regardless of the dose that they start out on. So if they start on a low or a high, it's still going to take a few weeks to build up in the system and be effective. And you can offer them to take it once daily at bedtime because it promotes sleep, facilitates adherence, and it has the CNS depression like we talked about. So if you take it during the day, your patient may be like sleepier or whatnot throughout the day. So we recommend that they take it in the evening. Here's just another list of other TCAs that you might hear, the brand name than the generic name. Okay, another question. So, a patient returns to his doctor's office 2 weeks after being prescribed Pamalor, a TCA. Which of the following statements indicate the patient needs more education about the meds? Select all that apply. The medication doesn't seem to be working for me. Can you try a new one? The doctor told me I should get another EKG today, but I had one 2 weeks ago, so I don't think it's necessary. I couldn't sleep the other night, so I took a Benadryl before bed. I moved positions slowly, and I know to call my doctor if I have any persistent dizziness or lightheadedness. ABC. Yep, great. Yeah, it's been 2 weeks. The medication's not working yet because it takes a few weeks to build up. He probably has a prior cardiac history, so I have EKG, so a second one definitely is indicated. Taking a Benadryl at night before bed while also taking the med is too much of a CNS depressant. We wouldn't want to do that. And D is good because he's moving position slowly. He knows to call his doctor if he has any further problems. Next med is monoamine oxidase inhibitors. You won't see this med as much as the other two. It's second or third choice antidepressants. It has a really high risk of running a hypertensive crisis, and also has a lot of drug food allergies. So these patients are only prescribed these meds when they've failed multiple other meds, and it's kind of like a last effort. So explaining the mechanism, so monoamine oxidase is an enzyme found in the liver. The function of monoamine oxidase in neurons is to convert monoamine neurotransmitters, like we talked about, norepinephrine, serotonin, and dopamine, into inactive products. So as an inactive product, they can exert their mechanism of action, which is not good for a patient who's suffering from depression. So we want the monoamine neurotransmitters, the serotonin and dopamine, to be present in the synapse. So we're going to block the enzyme. We're blocking the monoamine oxidase. And we're keeping the monoamine neurotransmitter in its active form. Does that make sense? We're going to talk about the food in a minute. I thought it was better to break it down this way. But also important to know that the blockade is irreversible. So you'll have to wait for the liver to form the enzyme again, which may take up to 2 weeks. Therapeutic uses for MAOIs, again it says here, it's for patients that have not responded to other safer drugs. Also atypical depression, which is just an abnormal, patient presents abnormally with weird depression signs, which your book talks about being happy briefly and then being sad again, and having heavy weight in your legs and arms, and that could be atypical depression. Its adverse effects, it's a CNS stimulant, so you can have insomnia, anxiety, agitation, hypermania, mania. You can also have orthostatic hypotension with these meds, and hypertensive crisis from dietary tyranny, which we're going to talk about on the next slide. Okay, so in addition to another effect of the enzyme MAO is to break down tyramine in your GI tract, which is found in a ton of foods. So it's very readily broken down in a regular patient who is not on an MAOI. It's very broken down in the GI tract, and it doesn't ever reach your systemic circulation. And that's great because tyramine can cause the release of norepinephrine, which can cause vasoconstriction, tachycardia, hypertension. So if the med that we're giving, the MAOI, is blocking the med, it's also going to be blocking this tyramine breakdown, or the tyramine from degrading food. So basically, if you're eating tyramine and it's staying in your system, it's not being broken down, it's going to cause accumulation of norepinephrine, causing massive vasoconstriction and causing a hypertensive crisis. Makes sense? So with these patients, education is very, very important. You're not only going to be verbally educating them and their family, but also giving them handouts and educational papers and everything. It's in a lot of foods, like avocados, cheese, figs, like things you eat every day. Anything's like dried, cured, fermented, bread, meat. It's in caffeine, chocolate. It's like a very common thing. That's why you'll see like these patients. It's like impossible, right? But so other drug interactions with MAOIs. So your indirect acting sympathomimetic drugs, your like stimulants, the ephedrine, amphetamines, things like that. They're also promoting the release of norepinephrine from the sympathetic nervous system. So you're further increasing the risk of having like a hypertensive crisis if your patient was taking those meds while also taking an MAOI. And there's no meds like the nasal decongestants like Sudafed, some asthma medications that are like your stimulants, and like cocaine, things like that. You need to teach your patients about that. TCAs and SSRIs, they can also cause hypertensive issues and serotonin syndrome. Antihypertensive drugs, so if you remember a few slides back, aside from like the tyranine and the hypertensive crisis, MAOIs can cause orthostatic hypertension too. So if you're on an MAOI and you're at risk for orthostatic hypertension and you add an antihypertensive, combining them can cause excessive lowering of the blood pressure. And then meperidine is listed there, also called Demerol, that just can cause excessive temp elevation and vasodilation. Another question, a patient with a diagnosis of depression is being discharged with a prescription for an MAOI. Which instructions should the nurse include for this med? Avoid eating H, cheese, take this med PRN as needed, and you don't have to worry about any over-the-counter meds interacting with this drug. Yes, correct. And then last is atypical antidepressants, so prototype for that is Wellbutrin. It's similar in structure to amphetamines. Its effects also take a little bit to build up, 1 to 3 weeks. Mechanism of action is unclear, maybe a blockade of norepinephrine and dopamine reuptake. A side effect with this is it actually increases sexual desire. So you'll see when we're talking about SSRIs how there's a 70% chance a patient struggles from sexual dysfunction. You'll see a lot of patients that can be on an SSRI and this, like kind of counter interact the effects. Also, other indications it can be used for depression, seasonal affective disorder, hyperactive sexual disorder, and it can be helpful with smoking cessation too. Adverse effects, seizures if the dosage is too high. Again, what's happening again? It's literally doing it at the exact same slide. I had this problem before, like just fast forwarding through everything. Alright, we'll try it one more time. Okay. So seizures if the dosage is too high, so you want to make sure you're titrating it slowly.
True.
You guys can see my notes. It literally, I don't know. Yeah, maybe. I'm really bad with computers.
Is it on the automatic?
It might be, but you guys can just see my notes for the last few slides. It's fine. Yeah. It'll be all right. I'm gonna take it for you guys. Is this okay?
Yeah.
Okay.
Oh, look at the top right there. It says use timing.
Yeah.
Hit that box.
Punch it.
Was it really that simple? It's okay. Alright, I'll just finish it this way. So, where are we at? So we talked about this one. So seizure with Wellbutrin, seizures if the dosage is too high, so you want to titrate slowly. You could also have agitation, headache, dry mouth, constipation, weight loss, GI upset, dizziness, tremor, insomnia, blurred vision, tachycardia. Also, drug interaction. So MAOIs increase the risk of Wellbutrin toxicity. So if your patient is being titrated off MAOIs and going on Wellbutrin, you want to discontinue it 2 weeks before starting the Wellbutrin. Because remember the MAOI, it takes 2 weeks for the liver to get rid of it and to build it up again. So you would want to titrate the patient off slowly if switching between those two meds. Another med, Remeron, this also blocks alpha-2, which increases serotonin and norepinephrine, also blocks histamine and selective serotonin receptors. This is a med I feel like we see prescribed a lot in like older people who just have no appetite because of depression. Um, it helps with depression, but also increases appetite and helps with weight gain. And we give it at night because it can help. It can cause like sleepiness. So for drug selection, like I talked about before, there's many factors to consider and many different drugs that basically have the same efficacy. So it's hard to determine which patient should go on which med, but it does help to match a patient's symptom profile. Like if they're fatigued, give them a CNS stimulant. If they have insomnia, give them something with sedation. Sexual dysfunction, you're going to give the Wellbutrin. And like, even though, we're not the people prescribing these meds, we are the ones giving them, so you don't ever want to give a med unless it makes sense to you. Somatic therapies that we talked about, electroconvulsive therapy. This is, I've never seen this done, and it's usually for like patients that require rapid therapy and are severely depressed or severely suicidal. It actually is like electrical like shocks delivered to the scalp that induce 20 to 30-second seizures. The patient is like put to sleep for it. They typically receive 2 to 3 per week for a total of 6 to 12 treatments. And like I said, it's for severely depressed, severely suicidal. Like there's older adults you'll see that are so depressed they just don't eat and they're like starving themselves. Or if they haven't responded to multiple different therapies before this, they'll try this. Transcranial magnetic stimulation. That's just placed against the scalp and gives like pulse magnetic fields. You don't have to be sedated for this. You don't get seizures or anything like that. And that's for 40 minutes for 6 weeks or so. Vagus nerve stimulation, that's just a device implanted and it stimulates your vagus nerve. Sends like electrical pulses. Light therapy, it's cheap and effective, and it's thought to be believed that light possibly enhances like serotonin neurotransmission. Like when it's nice out, like we all feel better, like that kind of thing. I think that's it. Does anyone have any questions on that one?
Yeah. For the vagus nerve stimulation, when you stimulate, is it? Do you think it's
What?
because usually when you stimulate your vagus nerve, don't you pass out?
I mean, you
You
can.
can.
Like, you have this thing like a vagal response. Is that what you mean?
Yeah.
Yeah, like you can have a vagal response, like vasovagal, like if you're having like a bowel movement, like pushing and things like that. But I would guess with this, like because you're with healthcare providers and they're doing the treatment, like it would be monitored. But through my research with it, it didn't talk about like the patient passing out or anything like that. But you are true. That's like a vagal response that people do have, or they can like pass out and things. Anyone? Okay, next we're gonna do bipolar disorder.
Is that mine? Oh, no.
Yeah.